The modern hospital room is a river of data. Monitors beep, monitors flash, displaying numbers that change with every breath and every heartbeat. A patient's chart is a digital scroll holding pages of lab results, imaging reports, notes from a dozen different specialists. Then there is the patient, the most important source. They have a story to tell, a feeling in their chest, a worry in their eyes. For the nurse at the bedside, all this information arrives at once. It is a constant, overwhelming flood. Hidden within that flood is the truth of what is happening to the patient. The challenge is not a lack of information. The challenge is making sense of it. Your job as a nurse is to be the synthesizer. Connect the flashing monitor number to the patient's whispered complaint. See how a lab value from this morning relates to the exam you just performed. It is an immense responsibility. A small change in breathing, a subtle trend in blood pressure, a new detail in their story. These are clues. Pieced together correctly, they form a clear picture. Missed, the consequences can be serious. This synthesis is not magic. It is a skill, a structured way of seeing, thinking, and acting. Turning raw data into a coherent diagnosis is the core of clinical nursing, where your knowledge and experience come alive. Without it, we react to alarms. With it, we command the clinical situation. In this guide, we'll break that process into a simple, repeatable playbook, from the flood of data to a clear, actionable plan. We call it the START loop. It is a mental habit, a quick cycle of thinking you can run through in minutes. START stands for see, tell, assume, run, take action. To make this loop even more powerful, we will pair it with 5 clinical lenses. Think of these as different angles from which to view the patient situation. The 5 lenses are story, trend, assessment, results, setting. Together they create a complete 3-dimensional picture of your patient. We will then apply the entire system to a dramatized case of a patient with a COPD exacerbation. You will see how to go from initial data to a working diagnosis, make critical decisions, and communicate using an SBAR report. This is your 10-minute playbook for turning data into a diagnosis and acting with confidence. The first step is see. This is about pure observation. What do you see right now at this moment without interpretation? Look at the monitor. Heart rate, blood pressure, oxygen saturation. Look at the patient. Next comes tell. This step is about constructing the narrative. You are connecting what you see to the patient's story. What does the patient tell you? Are they saying they have chest pain? What does their chart tell you? What is their past medical history? The third step is assume. Based on what you have seen and what you have been told, you now form a working hypothesis. For example, if you see a high heart rate and low blood pressure in a patient who tells you they feel dizzy and have had a fever, you might assume they are developing sepsis. Finally, we have run and take action. Once you have your assumption, you run a plan to test it. If you assume a heart problem, you might run for an ECG machine. After you run that quick check, you take action. This is your immediate bedside intervention. The START loop then begins again. The action you took creates a new situation to see, and the cycle continues, refining your understanding with each pass. The first lens is story. This is the patient's narrative, their personal account of their illness. It is often the most important piece of the puzzle. Instead of asking, "Is your pain sharp?" try asking, "Tell me what the pain feels like." The story also includes information from the family. They may have noticed subtle changes the patient has not. The second lens is trend. A single set of vital signs is a snapshot. A trend is a movie. Is the blood pressure slowly drifting down over several hours? Trends help you spot a patient quietly deteriorating. Never look at a number in isolation. Always ask, what was it before? The third lens is your assessment. This is your hands-on physical examination. If the patient tells you they are short of breath, your assessment is what happens next. Are you hearing crackles, which might suggest fluid? Or are you hearing wheezes, suggesting bronchospasm? The fourth lens is results. This category includes all the diagnostic data you get from the lab and from imaging. It is most powerful when compared to previous results to establish a trend. Is the troponin level going up? The fifth and final lens is the setting. This is the context in which you are caring for the patient. A fever in a patient on a neurosurgery unit might point towards meningitis, while the same fever on an oncology unit might suggest neutropenic sepsis. When you assume a diagnosis, you are synthesizing the story, trend, assessment, and results within the context of the setting. Your assumption is your best interpretation of all 5 lenses combined. The call light flashes at 3 a.m. The nursing assistant tells you he is complaining of shortness of breath. You walk to the room not with alarm, but with purpose. This is the start of your START loop. The first step is to see. Mr. Henderson is sitting upright on the edge of the bed. This is the tripod position, a classic sign of significant respiratory distress. You glance at the monitor. Heart rate is 118 beats per minute. Respiratory rate is 28 breaths per minute. His oxygen saturation is 86% on room air.
Mr. Henderson, I'm here. Tell me what's happening.
Labored. Can't catch my breath. Worse than before. Now you begin the tell phase even as you act.
He also mentions a cough that has been getting worse over the last day, producing thicker yellowish sputum. You assume this is an acute exacerbation of his underlying COPD. This working diagnosis provides a clear and immediate direction for your next actions. Start by expanding the story. A quick chart review. This history confirms his high risk. Next, trend. Last 6 hours. A subtle but clear pattern. This trend shows respiratory compensation was failing. Now, focused assessment. Instead of crackles, you hear diffuse expiratory wheezes in all lung fields. Breath sounds are diminished at the bases. Putting story, trend, and assessment together creates a cohesive picture. Each lens confirms the others. Your initial assumption of a COPD exacerbation is now much more solid. You now shift from assessment to action. Your first priority is to correct hypoxia. Target a safe level, 88 to 92%. Next, address bronchospasm. The fastest method, a nebulizer treatment with a short-acting beta agonist and anticholinergic. While the nebulizer runs, you run the key diagnostic tests. Call for a portable chest X-ray to rule out pneumonia or pneumothorax. Call for an arterial blood gas to quantify his respiratory failure. The results start coming back. The chest X-ray is negative for other causes, but the ABG is the key piece of evidence. It confirms he has acute on chronic hypercapnic respiratory failure. You have moved from a vague complaint to a precise diagnosis. With a clear diagnosis, your next action is to communicate. This is where the SBAR framework is essential.
Dr. Adams, this is Sarah, the nurse for Mr. Henderson in room 512. I am calling about his acute respiratory distress. He is the 68-year-old male with severe COPD, post-op day 2, who became acutely short of breath 30 minutes ago. His current vitals are RR26, HR115, SpO2 90% on 2 liters. His lungs have diffuse wheezing. His ABG shows a pH of 7.32 and a CO2 of 60. His chest X-ray is clear. I believe he is in a severe COPD exacerbation with respiratory failure. I have given 1 duo-neb. My recommendation is that we start IV Solumedrol, antibiotics, and consider BiPAP. I think he needs to be transferred to the step-down unit for closer monitoring.
Your structured thinking and decisive action have turned a potential crisis into a managed clinical event. The START loop is complete, and a new one begins. One of the most common pitfalls is anchoring bias. To avoid this, always ask yourself, what else could this be? A second common error is missing the trend. Make it a habit to always ask, what were the vitals an hour ago? The third trap is underappreciating the context. Always frame your findings with the questions, who is this patient? Where are they in their hospital course? Use a simple 4-question checklist for any patient you are worried about. It brings immediate focus to your assessment.
RR trended up to 28. SpO2 dropped to 88%. Patient states, I feel like I'm drowning. Use the rule of 3s for escalation. It prevents rambling and ensures your critical message is delivered with maximum impact.
The challenge and the art of modern nursing is to find the clear, coherent signal within this noise. The goal is to see the patient not as a collection of isolated data points, but as a whole person on a specific journey. Prioritize an awareness of the trend above all else. A single number lies, but a pattern tells the truth. Master a clear, structured communication method like SBAR, because a brilliant diagnosis is useless if it cannot be communicated effectively. By adopting these simple, structured habits, you transform information into understanding, understanding into action, and action into safer, better care for every single patient you have the privilege to serve.